Welcome to the Dementia Care Identifying and Managing Target Behaviors conference call. My name is Allie, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. I will now turn the call over to Christy Reardon. Please go ahead.
Thank you. Hello, everyone. This is Christy Reardon with Lake Superior Quality Innovation Network, or Lake Superior QUIN. We represent Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you this afternoon to this educational session. All lines will be muted during this webinar. However, after the presentation, we will have a time for questions and answers, so please make a note of any questions that may come up as you listen, or feel free to place your question in chat. Dr. Robert Sonntag is our speaker for this webinar. He has made it his mission to help nurses and other professionals working in long-term care to learn new skills to improve the care of the elderly. He offers a unique approach, sharing his clinical expertise and experience and anecdotes that make his presentations memorable and useful. As one of the first certified medical directors in Minnesota, Dr. Sonntag is the medical director for 7 nursing facilities in Minneapolis. In his medical director role, his primary purpose is to educate others and, as a result, provide better care to those in long-term care. He's also certified in internal medicine, geriatrics, hospice, and palliative care. We've often shared the National Nursing Home Quality Care Collaborative Change Package as a great resource to brainstorm strategies to improve quality in your nursing home. As a reminder, the change package that was created follows CMS's study of high-performing nursing homes, and the strategies and action items come from conversations and observations of staff at all levels of these organizations. Also included in the change package are 3 bundles focused on what nursing homes in the last National Nursing Home Collaborative did, as well as evidence-based practices to reduce the use of inappropriate antipsychotic medications, maintain and improve resident mobility, and reduce healthcare-acquired infections. I would encourage you all to review the strategies found in this change package as you work to reduce the use of inappropriate antipsychotic medications. The link to the change package is on this slide. Okay, Dr. Sonntag, I will now turn it over to you.
Well, thank you, Christy, for inviting me to do this talk. Antipsychotics is a passion of mine. And for the objectives, I'll let you sort of read the objectives, but I'm going to be emphasizing target behaviors. How do I change it here?
So up in the right here where this arrow is.
Okay. All right, so I want to share my first experiences. First of all, I'm a geriatrician. I am not a psychiatrist. I'm not a psychologist. And I was not trained in geriatrics. In fact, I did my residency in Milwaukee at a county hospital, and for the life of me, I don't remember anybody who came from a nursing home or that I sent to a nursing home, and I don't even remember behavior issues. So when I entered practice, I sort of stumbled into long-term care by default, and I really had no experience managing behaviors. And I always will remember Mr. Jones, because Mr. Jones was an elderly man. He was in a skilled nursing facility. He had some dementia, and one of his characteristics, he was able to take a cab, and he would take the cab and give people money. He'd stuff his wallet full of money, and he'd come back to the nursing home, and everybody said that we can't have this, and they asked me to put him on Haldol to prevent that. And I intuitively thought that was wrong, to put him on a drug to prevent him from doing that, although I didn't even really have any good idea what I should do. And the next thing I knew, I was fired. The nursing home got me fired. They got him another doctor who put him on Haldol, and Mr. Jones died in a week from the Haldol. That made a dramatic impact on the effects of Haldol. Another case was a Bill about the same time, early in my career. He was in a locked dementia unit, and he was on probably Haldol too. He was on some antipsychotic. And one day the nurse came up to me and said, Dr. Sonntag, we've had a med error. He has not gotten his Haldol for the entire month because it wasn't transcribed in the month orders. I said, well, that's good. Let's just stop it. So we officially stopped it. Well, within about 4 days, I got called and said, well, Bill needs to be back on the Haldol. And this was before I became very sophisticated. I probably asked what he was doing, and he was pounding on doors and things. So I started him back on the Haldol. And I regret that to this day, because what I realize now is that his behavior when people thought he was on Haldol was okay, but the same behavior when they realized he was not on an antipsychotic was not okay, and they wanted it back. And I can't remember what happened to him, but again, that also made an impression on me. And in addition, I had multiple other cases early in my career where I noticed the bad things of antipsychotics, primarily death and pneumonia. So all that stuff made an experience. So then it comes down to what are the indications for antipsychotics? And we know it's schizophrenia, delusional disorders. Mood disorders such as bipolar might be equivocal, but those are usually managed by psychiatrists. We are taught that Tourette syndrome, Huntington's disease, but also the choice of treatment for hiccups are things like compazine, some of the antipsychotics, nausea and vomiting associated with chemotherapy, is delirium, the drugs of choice. If you if you can't find the cause of the delirium, Haldol is the drug of choice. So there are indications for antipsychotics. The problem is some of the things that we perceive are indications for antipsychotics, I believe, are not. And for example, hallucinations. Frequently, I'm told that somebody has hallucinations, and I don't know how many people are familiar with Bonnet syndrome, but Bonnet syndrome is a syndrome that's characterized usually by some mild dementia and maybe some visual loss. Doesn't have to have visual loss, but typically the person sees friendly little people, particularly a little girl in a white prom dress. And they might talk about that. And those are really benign hallucinations. I've actually seen patients who have recognized that the patient is not there, and we just talk about it. It does not need medication. I remember one lady, Margaret, who actually just died at 104 of this winter, but she had been in AL, and she would see this little girl visiting her, and she'd tell somebody in the AL, and they'd send her to the hospital. They put her on an antipsychotic. They send her to the nursing home to rehab. I'd take her off of it, and she'd go back to her AL, and this happened again. She saw the little girl in the white dress, which was not a big deal, and they sent her back to the hospital. She went to the hospital. She came back to the nursing home on an antipsychotic. Well, of course, I sat down with Margaret, and I said, Margaret, what happens when you tell people about the little girl in the white dress? And she looked at me and said, they send me to the hospital. And I said, what do they do then? They put me on a drug. And then what? They send me here. And I said, Margaret, let's have a secret. Don't tell anybody about the girl in the white dress anymore. And she agreed. And that was sort of the end of it. So, again, hallucinations have to be harmful, and they can be benign. And then we come to delusions. When I do my rounding as medical director, as a staff physician, I hear a lot of things about delusions. But we also have to realize that people with dementia have misperceptions. For example, if your window's open and your closet door is open, your clothes might be waving in the breeze, and that could be perceived as somebody in your room or somebody in the closet. And if you talk about that, that's not a delusion. That's actual reality. So it's a misperception. And we as caretakers can perceive that as a delusion, the perception is that it might be a delusion, but in fact it's not. It's a misperception. Another thing that I think of is how dementia units are decorated at Halloween. Have you ever seen some of the dementia units with the spiders and the goblins hanging down? And I really wonder if anybody's ever done a study about changes in behavior during Halloween or in October in dementia units that are decorated, because I would think that our demented people would have a lot of misperceptions. And then we come to aggressive behaviors, and I put a question mark behind that because that's one of the most problematic things. I have on a couple of times started an antipsychotic for very aggressive behaviors when my intent is to prevent the person from going to a senior treatment where I'm forced. And have I been successful a couple times? But the aggressive behaviors has to be harmful to that person and maybe to somebody else. And again, it's a questionable indication. And then I include severe distress, which what I call inconsolable behavior, and target behaviors that present danger to person or others. This idea of an inconsolable behavior, think of somebody who is constantly yelling or moaning, and you do everything right. They're not in pain, they're not hungry, they've been changed, and I've seen these types of people, and they say, why are you yelling for help? And the answer is, I don't know. I've had nurse practitioners talk about some of these patients. I, as medical director, encouraged them to be taken off antipsychotic. I remember this one nurse practitioner told me, I'll do it, but it's not going to work. And he was right. So these are the types of behaviors that if you're going to use an antipsychotic, you really need to document it well and justify it. But there are times when you might have to use an antipsychotic for what I call inconsolable behavior. Now we get to the behavioral and psychological symptoms of dementia. This is a very important slide because these are the behaviors that are not appropriate for an antipsychotic. And we're going to talk about this a little bit later, but as a medical director, when I'm doing psychotropic rounds, these are often described as the indications in the plan of care. So wandering, unsociability, poor self-care, inattention, fidgety, mild anxiety, impaired memory. Of course, they all have impaired memory. Uncooperativeness, verbal expressions. Again, these are normal behaviors of somebody who's demented and are not indications for not only antipsychotics, but also they're not indications for other drugs such as benzodiazepines. Behavioral symptoms of dementia often are thought of as a medical problem. That's why the doctors and the nurse practitioners get a call. And what I call it is a doctor fix-it call, because if somebody's doing something and I get a call, I'm supposed to fix it. How do I fix things? I'm certainly not going to drive halfway across town. People are expecting a drug. And we also know that these kinds of behaviors are similar to behaviors of children in daycare, and we don't drug them, right? And when you think of the children's behavior, uncooperativeness, yelling. So these behavioral symptoms as a medical problem, I'll give you an example. I remember I was sitting at a desk once, and there was a patient who had some mild dementia. He was in the middle of the hallway in his wheelchair, and he became uncooperative to the aide. The next thing, the nurse came, and he got louder. The nurse got louder. And then the social worker came, so now there were 3 people around his desk, or around his wheelchair. And then somebody else came. And then finally, the administrator came. There were 5 people around him, and they were all telling him to be quiet, slow, and I'm just sitting at the desk listening. He was my patient, but what am I supposed to do? And finally, the administrator looked over and saw me sitting there and said, Sonntag, do something. So I got up and I walked over to the wheelchair and I said, you know what? Everybody needs to leave and just leave him alone. Because 5 people around his wheelchair, he was getting agitated. That's not the way to calm him. And I've seen that happen many, many times. It's sort of an example. I can't fix that. So when I think of behaviors and what needs to be done when somebody has a behavior, I think of 4 things: unmet physical needs, unmet psychological needs, environmental causes, and psychiatric causes. We're going to go over each one of these. Unmet physical needs: pain, illness, dehydration, sleep disturbance, sensory deficits, constipation, incontinence, and then medications. These are examples of things that can cause behavior issues. I had lunch once with a physician who manages one of the geriatric treatment centers, and I asked him, I said, what do you find is really a frequent cause of these behaviors? And he said, unrecognized and unmanaged pain. I'm certainly not suggesting that everybody be put on an opioid, but when somebody is being agitated, it is important to think of pain and maybe trying some medication for that. Dehydration, medical problems, infection certainly can cause behavioral issues. And sleep disturbances. People who are not sleeping well. I've had people who actually had narcolepsy who would get up out of their bed and they fall before they get to the bathroom because they went to sleep. Maybe that's not a behavior, but sleep disturbances can. Sensory deficits. I think of hearing problems and visual problems. When I talk about sensory deficits, I always suggest that I would rather be blind in a nursing home than deaf, because if I'm deaf, I don't hear the person knocking on the door. I don't hear the person saying that they're going to change me. And then the next thing I know that I'm touched, and what might I do? I might strike out. Constipation is an issue. Incontinence, and then medications. I really, whenever I look at a person with a behavior issue, I'm always looking at medications. And there's a lot of different medications that are out there that we don't even perceive as something that's causing a behavior. Aricept, for example, causes bad dreams and anxiety. Imagine if you're demented and you have bad dreams, abnormal dreams. And you might say, well, that never happens. I've seen that 3 or 4 times in people with mild dementia who's been on Aricept. And if you're severely demented, how do we know it's not happening? I had one lady who used to yell and yell, and I did everything. And I finally looked at her medicines. She was only on 3 or 4, but I know she was on cardizem. So I looked up cardizem. Cardizem, diltiazem, which is a cardiac drug. It sort of listed anxiety and some other neurological things. So I stopped it. She got better. Is it just me saying that she got better? No, the nursing staff said she got better. And those are the kind of things so that whenever I see somebody with the behavior problem, particularly fidgeting, yelling, anxiety, I look at their drugs and I pull out my little drug reference and I take a look and say, are any of the drugs that this person is on, could that be causing the behavioral issue? So that's very important to be thinking about. So those are your unmet physical needs. Then you get unmet psychological needs. And I think that this is an area that's neglected in skilled nursing facilities. People are bored. They're lonely. They worry. They might have emotional discomfort that we're not even aware of. Maybe they're depressed. Lack of enjoyable activities. Not everybody wants to play bingo in the afternoon. Lack of socialization, loss of intimacy. When I look at this slide, one of the things that I think about is the person who yells a lot. And most of those people, if you come and touch them, they stop yelling. But what I have seen sometimes, because they yell a lot, they're put down at the end of the hall so that nobody can hear them. And when you think about that, they're being isolated, okay? And there's going to be less likelihood that they're going to have socialization and people are going to be touching them and talking to them. So we really also need to be thinking about the psychological needs. Environmental causes, noise, call systems, overheads are thought to cause behavior problems, and there's been some suggestion that if you decrease the overhead noise that you have better behavioral management in your facility. Institutional routines, lack of cues and prompts to function. But the big issue here is caregiver approaches. I'm convinced that many behaviors are related to caregiver approaches. And we're going to talk about this a little bit more, but the point here is that resistiveness to cares, which I frequently hear about as a indication for a drug, is not the patient's problem. It's a caregiver problem. It's our problem. We need to learn how to approach that person better and differently. also when I look at this slide about level type stimulation as noise or lighting, it brings to mind a story that I don't know if it's true, but it's a good story. They have this guy at a dining room table that for unknown reasons he would get up out of his chair and punch his table mate in the face, and then he would sit down and eat. And you know how that doesn't go over very well. And nobody could figure out what was happening, so they were getting ready to ship him out to one of the senior treatment units because we know he needs a drug for that kind of behavior. But the social worker started looking at his chart, and she recognized that in his youth he was a boxer. And he was sitting next to the elevator. And what was happening was the elevator door would open with a ring, which is a noise, and he thought that was the sign that he had to come up fighting, so he'd come up fighting, hit the guy, sit down, and all they had to do was move him away from the elevator, and the behavior went away. So behaviors can be strange. And then there's psychiatric causes: depression, anxiety, psychosis, other mental illness, and delirium. So behavior problems, depression as a geriatrician I can treat, anxiety, psychosis, some of the severe mental illnesses, I frequently would like to defer to a psychiatrist, particularly when there's significant mental illness. If you have a geriatric syndrome that they clearly are psychotic with very disturbing delusions, I would start an antipsychotic, but that doesn't happen to me very often. Anxiety, I'm always very careful. I don't like to use benzodiazepines. Benzodiazepines make people fall. And the big one is delirium. And when you read hospital notes, you frequently read about the diagnosis of delirium. But in the nursing home, we refer to delirium as sort of as a change in behavior or confusion. And what happens is we don't recognize what the underlying cause is. And delirium usually is related to some sort of a medical problem. And unfortunately, it can be hyperactive, hypoactive, or mixed. But basically, the person is more confused than usual. And what we need to be thinking about, and unfortunately, the symptoms of delirium are things that we've been talking about: agitation, confusion, delusions, irritable thinking, disorganized thinking, labile affect. Some of these people actually get labeled as demented, and I've seen that. But delirium is a consequence of a medical illness, and it might be more easily occurring when somebody's demented. It'll enhance and maybe change some of these behaviors, but in itself, it is not dementia. And what we need to be thinking about is what is the medical cause of the delirium. So when we're looking at delirium and some of these symptoms, we need to treat the underlying cause. So if it's a drug that's causing confusion, we need to take away the drug. Let's say you have an exacerbation of COPD, which is causing hypoxia, which is causing confusion. We need to treat the COPD. One of the problems here sometimes when somebody is confused, instead of trying to do a complete assessment, and the assessment is very important, there's band-aids that occur. For example, a UAUC when somebody's confused. That is one of the most terrible things one can do because you have no idea what really is causing it. So we need to really look for the underlying cause, which means that you need to do a complete sort of history and do some critical thinking. We need to keep the patient safe. And when I talk about non-pharmacological and pharmacological symptom management, the non-pharmacological is maybe having family there if somebody is restless and confused to calm them down. Pharmacological symptom management, if you have a COPD exacerbation, it might be using oxygen, a nebulizer. Basically, it's the medical management of the issue that's causing the delirium. The last thing, and unfortunately, antipsychotics, i.e. Haldol, is thought to be the drug of choice for management of delirium. That should be at the end, only when everything else has been tried and when you're trying to manage the underlying illness or medications that's causing the delirium, the confusion, and so forth. Okay, psychotropic drugs. This is something that I have done as a medical director. We call them different things, but one of my homes we call it the Medication Management Committee. And we have the medical director, the psychologist, the consultant pharmacist, the social worker, the nursing staff, sometimes the administrator, and sometimes one of the aides or one of the nurses. And we do 5 charts at a time. 5 charts takes us about an hour. We've been doing this for a couple years. And we go through the medications. We're presented with the behaviors, and we talk not only about the psychotropic medications, but other medications. Frequently at other homes, we do selected psychotropic rounds looking at, for example, antipsychotics with the intent of reducing the antipsychotic. Anybody who's attended one of these with me knows that my first question is, what is the target behavior? And if you remember the behavioral and psychological symptoms of dementia, that is not a target behavior. Okay, and very important. What is the target behavior? And we're going to talk about this, but we want specifics. And then, so we're talking about describing the target behavior accurately. The other thing is, the target behavior really a problem? What was the antecedent? That's example with the guy with the hitting his room or his table mate when the elevator bell goes off. There was an antecedent. I've had issues where somebody says that so and so threw a knife at his roommate, and I pause and I stop. Like, what's the punchline? What am I supposed to do? And I said, but his roommate threw a glass of water at him first. Okay, so what is that supposed to mean? So the guy threw the knife at him. Do I need to do something? So we need to understand that. Is there a reversible condition? That's, for example, pain, constipation. Those are the medical problems. And then the other question is sometimes we see people on a drug, for example, Seroquel, 12.5 milligrams for something, and my question is, I'm always going to be asking, what is the target behavior? And is it working? And if everybody at the table says, well, for one thing, if nobody knows what the target behavior is, then it's a good possibility that the drug's not needed. But if everybody says that the medication is not working, then you either need to stop the medication or you increase it. And I have to say that I'm not likely to suggest increasing it. But understanding what the target behavior is extremely important. And so these are the poor examples of target behavior. So when I'm sitting in psychotropic rounds, I ask the target behavior, and frequently it'll be agitation. Well, it doesn't take very many of these meetings that the people at the table understand that's not the target behavior, but it's probably listed in the care plan, okay, or in the MAR where you're checking off, how often do these behaviors occur. Other ones I hear, resistiveness to cares. I can't stand that term. That's not the patient's problem. That's our problem. Wandering, yelling. Maybe who knows why they're yelling. Maybe they're in pain. Uncooperativeness. I have people in this room who know that I'm uncooperative, right? And by the way, I don't need an antipsychotic for that. Physically aggressive. Well, that's a different thing. But if somebody says they're on an Seroquel for physical aggression, I'm going to want to understand, what are you talking about? In what context? Paranoia, hallucinations. Again, we talked about that earlier. That there are certain kinds of paranoia and hallucinations that we don't want to treat, or that we don't need to treat if they're not harmful to the person. So in my psychotropic rounds, invariably, when you start this type of a committee in your nursing facility, you're going to find that these are the things that are listed as the target behaviors. And these are very, very poor examples of target behaviors because it doesn't really describe what the problem is. So, good examples of target behaviors. We need to describe the behavior accurately and provide examples instead of just saying resistive to cares. And so we need the details. What the interventions are. Who is the behavior affecting? That's always important. And then instead of describing the behavior in general terms, be specific. An example is he yells when he is left alone at the dining room, or he grabs at the NAR's clothing during morning cares. So that's a target behavior that I want to know. So that when you're sitting in these psychotropic rounds, you start understanding the target behavior, and then you start working down, is this even a target behavior that's going to be affected by a medication? And it's pretty clear that yelling when somebody's left alone in the dining room is not a target behavior that's going to be affected by a drug. Or somebody who grabs the NAR's clothing during morning cares, that's not going to be affected by a drug. So, and if you forget what the appropriate target behaviors are, then go back to one of the first slides, because those are the things that we need to be looking at for reasons we starting these antipsychotics. Okay, so the other thing is we have to document what's working and what's not working, so that if we do start a drug, and one of my biases in nursing homes is that we start a drug and nobody ever really thinks is the drug working. That could be an antidepressant, it could be a blood pressure pill, it could be an antipsychotic. We need to be thinking, is there a change? And do we need more information? And all that's very important. Now, there are certain kinds of behaviors in certain facilities that the facility might not feel capable of managing, and then there's other issues about how do you get the patient out of your facility, but that should be relatively rare. So what should you document? You need the details. Does the behavior occur every day, every shift? What is the resident actually doing? And again, saying that resident is acting up is not specific enough. You need to say the resident throws the book at the nurse when she walks by. Using quotes is effective. Some of the things you might document is your contact with physician, psychologist, psychiatrist, and also what kind of interventions and effectiveness what kind of interventions and if they've been effective that you've tried. Because when I get a call about a behavior, I'm going to be asking about a lot of these things if I'm being called on the telephone. Staff approaches are the most frequent causes of behaviors. I firmly believe this because I run into this concept of resistiveness to cares. And resistiveness to cares is a caregiver problem, not a resident problem. And the other thing is that since I've been doing this and since I've been a medical director, I frequently observe and I watch how staff talk to residents. And if you sit back there in the nursing facility, sometimes watch and listen, you can see that staff often do not approach residents the right way, and sometimes not even with dementia. And what happens with some of the behaviors, then staff also takes these behaviors personally and reacts by scolding or getting angry. And I think we all know that if you scold a person with dementia, you're not going to get very far. The staff, particularly probably nursing assistants, and maybe a lot of nurses, don't realize that behaviors can be a symptom of a bigger problem. Medication issues, acute illnesses, things like that. And the staff tends to focus on the results of the behavior instead of the cause. A good example is the person who threw the knife at the other resident. And if they don't really think about the cause, which was the other resident threw a glass of water at the first resident. Throwing water is, I guess, better than throwing a knife. So we need to be thinking about that. And then staff will tend to argue or try to reorient residents with dementia, and they get frustrated. Arguing and correcting a person with dementia gets you no place. You do have to reorient. By reorienting residents is basically diverting them and trying to make them stop thinking about what behavior that is being objected to. Okay, so results of our own behavior. residents feel rushed and pressured. So what I think of in the nursing homes is, somebody mentioned this, one of the problems we have are tasks and time. And for the life of me, I don't know how a nursing assistant can get 10 people up or more in the morning for toileting, breakfast, and everything else. And I'm sure that residents feel rushed and pressured, and that can cause behavior problems. Residents are not given choices, right? You get one bath a week on Thursday at 8 o'clock in the morning. What if I want my bath at 10 o'clock? Right? What if I want 3 baths a week? I mean, I had that happen in the last couple of weeks. A resident on the TCU wanted daily baths. The policy was 3 baths a week. Well, we fixed that, right? You need to be able to provide choices. And then as these lack of choices develop, the resident is frustrated. That can cause behavior problems. They become fearful or angry. And then new behavioral symptoms develop, whether that's yelling, whether that's resistiveness to cares, or existing behaviors worsen, and catastrophic reactions may occur. And these are the types of things where the resident grabs an aide's arm, right, or scratches them. And I will contend that most of that is related to how the care is given, and that the staff person has gotten too close, right, and in a way that has upset the resident. So our own behavior is very, very important, that we have extra training in how we're relating to our residents, and how we can prevent what is referred to as resistiveness to care. Basically, you have to come back. And the other concept is that behavior has a meaning. That when a resident is yelling or something, it might be out of fear, it might be pain, it might be frustration. And what they're trying to do is they're trying to communicate. And what our job is trying to figure out what they're communicating. And that's not always very easy. It can be very difficult. And I've given some examples about trying to understand drugs, for example, that might be causing problems. But we need to assess, again, back to the basics: the pain, the drugs, the bowel issues, the incontinence. All of these are extremely important for us to sort of to go over, to try to get a context of what's happening. Suggestions to change our behavior, because we have to accept the patient's reality. If they have to go to work and they're looking for their car, we help them find the car and we distract them. We use social graces, because even the demented person can perceive reflections in our voice if we're angry or if we raise our voice. And this idea of removing time constraints and task-oriented goals is very important. I don't know how that's done when you take care of so many people, but I think that causes a lot more behavior problems than we give it credit for. We need to provide opportunities for the residents to succeed. That they can get dressed as much as they can, that they can feed themselves as much as they can, and find a path of least resistance. A good example of this: if they don't want a bath at 8 o'clock, you can come back at 9 o'clock. If they don't want a shower bath, maybe they appreciate a bed bath. But we need to always be thinking about what else can we do, or how else can we provide the care in a different fashion. Changing our behavior, we have to redirect with a positive approach. That's tone of voice. We need to learn how to distract and divert by coming back again. Sometimes you have to do it again. Do not correct or shame. Watch our attitude. Monitor your body language and tone of voice. And don't use all your energy trying to change what you can't change. Go with the flow. In other words, if the person's trying to find their car to go to work, help them find the car and then distract them. Reminds me of a little story that I was doing in a nursing home. First day as medical director, and I was sort of walking around. I was at the desk, and this nurse was sitting at the desk trying to do her paperwork, and this little old lady came right across from her and started jabbering away, not making a lot of sense. And I could see that the nurse was getting frustrated. Okay, I could tell the way she was talking to the patient. You could just see interactions. So I finally said, so-and-so, this lady in the wheelchair is really, she didn't know, the nurse didn't know who I was. I said, it appears to me that this lady is really bothering you. And she said, boy, is she ever. And I said, well, what do you do when she bothers you? She said, I give her some Ativan, which of course is the worst thing to do. Okay, she didn't use any of these things. Didn't use any of the principles of behavior monitoring. I just sort of smiled. Talked to the director of nursing about how they had to change the behavior of the staff. This is there's an article by Wollicher in the Journal of American Medical Directors Association. I've heard him speak, and his article is about modifiable factors related to abusive behaviors and dementia. In other words, what causes abusive behaviors? And he concluded there was basically two things. There was a lack of understanding leads to resistance to care. In other words, that the patient lack of understanding leads to resistance to cares. And then depression. And he specifically mentioned that the serotonin deficit which is related to depression, might actually exacerbate abusive behavior. So what he was recommending was trying to train our staff in such a way that we can eliminate the lack of understanding. But he was actually recommending an SSRI to treat the serotonin deficit for management of behavior. And let's just go back here. And that's been my drug of choice. So if I have somebody who is having some dementia-related behavior problems, I typically try an SSRI, and I usually do Celexa. And there's been some literature suggestion that you actually have to push it up to 30 milligrams for some behavior modification, which unfortunately is 10 milligrams over the recommended dose. But I would encourage people to consider that. So if I have somebody ramping up and we're doing things pretty good, but I can see that we're heading to the point where the staff is going to want, unfortunately, something else, I intervene and I usually start the SSRI. And again, I usually use Celexa. Then we get to the antipsychotics. When you review the literature about antipsychotics and the management of behaviors in dementia, risperidone tends to come out on top. Unfortunately, I don't see that used as frequently for behavior issues in nursing homes as some of the other ones. But we also know that antipsychotics are associated with increased sedation, falls, anticholinergic effects, sudden death, heart attacks, pneumonias. And if you remember the first patient I talked about, Mr. Jones, who died, he died because of the antipsychotic. Probably got too much Haldol and had pneumonia. Why do we use antipsychotics in dementia? It's a good question. They're harmful. They're used off-label. They're thought to be relatively ineffective in treating behavior. Usage varies from facility to facility, and I have an opportunity to look at Minnesota nursing facilities' use of antipsychotics, and it's very variable. My perception is, I think the state of Minnesota is around 15%. I think it could be lower. In facilities that I'm medical director at, I'm aiming for at least under 10, assuming that you're a typical long-term care facility, not some sort of other mental health facility. But I think we can do better than 15%. And using these antipsychotics are based on a misunderstanding of behavior and dementia. We've talked about that. And then there's the concept that a medication will simply make a person stop doing something undesirable and quickly. Boy, I tell you, if we had a drug like that, wouldn't that be great? We could give it one drug to everybody, and everybody would just do everything we wanted. Why do we do this? If all we have is a hammer, everything looks like a nail. I learned that when I was in high school. I worked in a factory, one of the guys in the factory said you could fix anything with a hammer. And then I find out that same thing in medicine. So suggestions for managing behaviors. I can't stress how much we have to identify the target behavior and make sure that it's an appropriate target behavior. We need to look for reversible causes such as pain, medications. We need to treat depression and pain, just mentioned that. We need to change the culture of our facility by being open-minded and not defensive, because when you do medication management meetings, there's often a defensiveness in the staff. They're not willing to change. Drugs are not always the answer, the idea of the doctor fix-it call. Use drugs only for appropriate reasons, and we need to monitor for the effectiveness, and we need to do dose reductions, or even stop it if they're not being effective. We need to get our medical directors involved. Psychiatrists tend to prescribe medication, so one always has to be a little careful about that. I've been in many facilities where even the administrator says, when I have a psychiatrist come into the building, my antipsychotics go up. I believe that mentally ill patients, the people with schizophrenia, I'm not a psychiatrist. I'm not trained to manage that. So we need to get psychiatrists in to help manage these patients. That's a problem. There's a barrier. I think that facilities should have a champion. It doesn't necessarily need to be the medical director. It could be a nurse. It could be the social worker. But somebody who understands the concepts and the indications and who is willing to champion dose reduction and other management of behaviors. We need to provide caregiver education and support. This is why I give this talk to my nursing home staff. We need to train staff in problem solving of specific behaviors, because we need to not just look at the results. We need to think of what's causing. And then I have a button that somebody gave to me that has a little red circle with a line through it that says, just say no to antipsychotics. And I think I'm done. These are references. Most of the things that I talk about are in the references. I was supposed to leave 10 minutes for questions. So do we have questions?
Thank you.
Yeah. Please remind our participants how to get in queue for questions, and you can also add them in the chat box if you'd like.
We will now take questions. If you have a question, please press star then 1 on your touch-tone phone. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers.
Okay, well, we're waiting for questions. I have one.
Okay.
So a lot of homes that we talk to, they do talk a lot. And as long as you're a medical director, this is a good question. But how can you really engage your medical director in helping you reduce the use of these medications if you're not getting a lot of support? Do you have any ideas?
Well, that's a good question. The question is, how do you engage your medical director? Hopefully your medical director is interested in reducing not only antipsychotics but other drugs. And one of the things you can do is make sure your medical director attends geriatric conferences such as AMDA, the Minnesota Medical Director Conferences, maybe having some of these references. The University of Iowa website has a lot of good references, and basically provide education to your medical director.
Thank you.
And we do have a question from Kathy Sasser. Please go ahead. Your line is.
Is that on the chat line?
No, it's on the audio. Kathy, you may be on mute.
Well, Kathy, we can't hear you. Maybe you could put your question in the chat box. And in the meantime, we have a question from Wendy. Do you have specific educational material when training nursing home staff?
Okay. What's the question? Do I have
educational material when training nursing home staff? I'm CNA staff. I can say, I don't know if you have anything to say, but some of you should all have the hand-in-hand manual that was sent out by CMS to all nursing homes about 4 or 5 years ago. Really great training materials there. they have CDs. You could show examples of, they have little like play acting type of thing that you can respond to. And the manual actually has good questions to get conversation going with nursing assistants. So that's one thing I know that's available free of charge, and you should have that somewhere in your nursing home. Again, it's called a hand-in-hand manual.
Right. I see the question now. As a physician, most of my training is related to the nurses, but I think that this talk that I've given is applicable to CNAs to understand. I also see a second question about sexuality. I do have some comments about that. It typically is an issue with a man being somewhat sexually aggressive and fondling, let's say, residents of the other sex. And Paxil, the SSRI Paxil, has been promoted as decreasing sort of the sexual desire. So SSRI Paxil is one drug that I've used. And then I ran across a recent article about cimetidine, which is Tagamet, because Tagamet has somewhat of an anti-androgen effect, and there was a case report where rather higher doses, I think it was 600 or 900 milligrams a day, was effective in reducing sexual behavior. And I've never tried that, but that's a relatively benign drug that I would suggest trying. So if I had a problem, I'd probably start the resident on paroxetine, which is Paxil, and consider cimetidine. And the other thing is, when you talk about the antipsychotics, they basically say that they're the last resort, and they're not going to be particularly effective for this. Way back many years ago, I put some men on estrogens, but that you need informed consent, and I don't see anybody doing that. But that's another, I guess it's another possibility. So I hope I answered that question.
The other thing that I hear, Dr. Sonntag, is a lot of homes concerned about the use of Haldol, like for end-of-life patients or residents, and they say that a lot of the reason that they can't bring down their numbers is because this is a standard order for hospice residents.
Okay, so the question is Haldol at the end of life, and that's a very interesting question because there's going to be new regulations that you can only use these drugs PRN for 2 weeks without a new prescription, which might taper down some of the hospice use of that. The other thing about Haldol was there was a recent article about antipsychotics. I think it was Haldol versus placebo in end-of-life delirium, and they found that placebo was just as effective as Haldol. So it might be that that we may not need as much Haldol, and there might be some regulatory issues that prevent that. But the bottom line, though, is that Haldol is a drug of choice for hospice end-of-life delirium when you're using a drug. And I know that it counts as, I believe it counts as one of your numbers in your for your quality indicators. Although it might be an exception.
It is for the Minnesota Quality Indicators, but not for the federal quality measures.
Okay.
Yeah.
So it's sort of a dilemma where you have an issue where the antipsychotic is actually the drug of choice in end-of-life. And then, talking about end-of-life, one might say, well, why don't we use Ativan in place of Haldol? Well, it turns out that Ativan actually causes more distress and is not recommended for delirium at end-of-life, that it can actually make delirium worse. So you're really sort of stuck as an alternative as in a hospice patient who is experiencing terminal agitation, where the drug of choice would be Haldol.
Thank you. Anyone on the line, operator?
We have no questions at this time.
Okay, I just see a question about, can we print off the slides? You can certainly print the handout. I don't know, Sandy, if that's the question you had. Did you actually want the slide? But anyway, the slides are available here.
You want me to give you my email address, and if you email me, I'll just forward the slides?
Sure. You want to just put it in here?
Yeah.
There you go. Thank you, Dr. Okay, while he's doing that, I just want to let everybody know that as you exit from the webinar, a window will open to a short evaluation, and so please take a minute to provide feedback on today's session. Once you've completed the evaluation, you will receive a certificate of completion. And if we don't have any more questions, which looks like we don't, this session was recorded and it will be available on the Lake Superior Quinn YouTube channel in about 2 weeks. If you can't find it, just contact your Quinn, whoever your lead is in your state for Lake Superior Quinn, and they'd be glad to show that to you. And thank you again, Dr. Sonntag, for speaking with us today.
You're welcome.
Really great information. And everybody, have a great afternoon. Bye-bye.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.